buenas tardes. Mi nombre es Fernando Romanelli, soy secretario de la Fundación ASIAPO. En nombre de la Fundación nos alegra muchísimo poder presentarles una nueva alternativa de tratamiento para el cáncer de mama, y para eso contamos con la presencia del doctor Seth Wander, oncólogo médico del Hospital General de Massachusetts y la Facultad de Medicina de Harvard, con un interés en la investigación clínica y translacional en el cáncer de mama y la genómica del cáncer. El doctor Wander trabaja tanto en la clínica como en el laboratorio, donde sus intereses de investigación involucran los mecanismos genómicos de resistencia a terapias dirigidas en el cáncer de mama metastásico. El doctor Wander ha publicado más de 40 manuscritos revisados por pares centrados en el campo emergente de la medicina de precisión y temas relacionados en oncología. Es uno de los investigadores clínicos y oradores más reconocidos en el área del cáncer de mama, incluida la enfermedad con mutación ESR1. Ha presentado sesiones educativas e investigaciones originales, tanto a nivel nacional como internacional, relacionadas con la resistencia a los medicamentos y el desarrollo de estrategias del tratamiento personalizadas para el cáncer de mama. Muchas gracias a los presentes y a los que se conectan virtualmente. Los dejo en manos del doctor.
Thank you so much. It's a great pleasure to be with everybody. I really appreciate the invite. I'm sorry we're doing it virtual. It would be fun to visit everybody in person. Hopefully in the future we can do that. It's my pleasure to join you today to talk about emerging insights related to acquired ESR1 mutations and personalized therapy for hormone receptor positive metastatic breast cancer. This here in the background is a picture from Boston before the snow starts falling in another couple of weeks probably. Here are my disclosures. And I wanted to start with a case. We'll talk about a couple of clinical contexts today. This is a 67-year-old postmenopausal woman without any significant medical issues. She presents with chronic low back and hip pain and was diagnosed via imaging studies and subsequently a biopsy with de novo metastatic breast cancer in the bone. It is estrogen receptor and progesterone receptor positive, HER2 negative with an IHC score of 1+. She receives in the first-line therapy letrozole and ribociclib and has a good response for 1.5 years. Actually, 36 months, so 3 years. She then develops progression in multiple bony areas with 2 new liver lesions, and her laboratory studies, her liver function tests are normal. So one of the questions would be, what additional diagnostic workup would the team like, and what are the optimal therapeutic options? And we'll begin to cover these now. Here are some of the things I want to discuss today. I want to talk a little bit about resistance mechanisms to standard therapy in metastatic breast cancer, how to test for ESR1 and other actionable alterations. We'll review data from the EMERALD trial, looking at elacestrant monotherapy, now FDA approved in the US. And we'll talk about some other drugs that are coming along, next generation oral anti-estrogens. And then we'll talk a little bit about patients who have multiple targets, including the PI3 kinase pathway. So let's start with resistance mechanisms. So ESR1 alterations occur in the gene that encodes for the estrogen receptor. And the important message here, and this was a nice review from my colleague Renath Jeselson a few years ago, if you look at primary tumors, the rate of mutation in ESR1 is very, very low. But when you begin to sequence metastatic tumors that have progressed on prior anti-estrogen therapy, typically with an aromatase inhibitor, we see significant increase in the frequency of these alterations. They tend to occur in the ligand binding domain of the protein, as you can see at the bottom, and they cause the protein to be constitutively active. So even in the absence of estrogen, the receptor becomes active. And that explains why the aromatase inhibitors, which reduce estrogen, cease to function. So they tend to occur under selective pressure on these drugs. Now, the impact of these drugs is very clear when it comes to aromatase inhibitors. They cause resistance to all available aromatase inhibitors, and you can see that up above in the SOPHIA and the EFFECT studies. Here, for patients that receive exemestane on the left-hand side, if they have ESR1, they do significantly worse than fulvestrant. Here, if they're ESR1 wild type, if they're normal, they do equally well on both sides. This is real-world data that we recently published just this year in 2024 that basically show the presence of an ESR1 mutation does not impact the response to a CDK4/6 inhibitor, which you can see here, but it does impact overall survival. It's a prognostic factor for inferior outcome in overall survival. I think the response to fulvestrant is controversial. So here's data from Plasma Match. This was published a couple of years ago by Dr. Turner. Here we had over 70 patients who were ESR1 mutant. They got high dose, double dose fulvestrant, but the PFS was only 2.5 months. This was a heavily pretreated population. They had had several lines of endocrine therapy and many had had chemo, but certainly suggested here that just because they were ESR1 mutant did not mean that they were definitely going to respond to a SERD. This was from a review that my fellow, Dr. Lloyd, published a couple of years ago. This is summarizing the different areas that we've identified in the laboratory that have provoked resistance to endocrine therapy and to CDK4/6 inhibitor therapy. On the left-hand side, you can see cell cycle regulatory proteins, FAT1, microRNAs that impact CDK6, cyclin E and CDK2, RB, aurora kinase. These have all been shown to drive hormone therapy and CDK inhibitor resistance. On the right, you see oncogenic pathways, receptor tyrosine kinases, FGFR, HER2, the MAP kinase, RAS pathway, and the PI3K pathway. In yellow, you see potential areas where we have drugs that are either currently available or may soon become available in clinic where we may be able to target some of these new resistance mechanisms. So what about testing for ESR1 and these other alterations? This is a summary of progress over the last 50 years for patients with hormone receptor positive breast cancer. We saw the development of tamoxifen in the late 1970s, and then the aromatase inhibitors in the 1990s. And then starting in 2015, we saw the first approvals in the US for the CDK4/6 inhibitors, palbociclib, ribociclib, and abemaciclib. Now on the far right, we have 4 relatively new drugs over the last few years that all require specific molecular genetic changes in the tumors to be utilized. We have the PI3 kinase inhibitor alpelisib. We have the oral SERD that we'll talk about momentarily, elacestrant. We have the AKT inhibitor capivasertib. And we just a few weeks ago got an FDA approval for the second PI3 kinase inhibitor, inovolisib, in the first-line setting. So all of these require the genetic changes that I have highlighted here for the patient to be able to access the drugs. And we'll talk about some of that data today. Now, when do we test for ESR1 and how do we test? You can do sequencing of solid tumors or you can do sequencing of blood. So one of the really important key points here is that if you're going to sequence a tumor early, either at the time of initial diagnosis or before they've had anti-estrogen therapy, there's a good chance that you might miss an ESR1 mutation that will arise later over time. Mutations like PIK3CA tend to be what we call truncal. They're there early in the course of the disease. So no matter when you sequence, you're likely to find them, as opposed to acquired mutations, which tend to arise later, only after progression on therapy, like AKT, PTEN, or ESR1. And this is a real-world example of that from one of my own cases. So let's talk about the EMERALD study and some of the important new phase 3 data that led to the first FDA approval of an oral SERD. Here's the schema for the EMERALD study. These were postmenopausal men and women with hormone receptor positive, HER2 negative advanced breast cancer. They were allowed to have had up to 1 prior line of chemotherapy, and they had to have had 1 to 2 prior lines of endocrine therapy with a CDK4/6 inhibitor. There were over 460 patients, and they were randomized to receive endocrine therapy of clinician's choice. Most of them got fulvestrant versus elacestrant, the first oral SERD. And the primary endpoint was progression-free survival by blinded central review. Secondary endpoints included overall survival, outcomes in the ESR1 subgroup, response rate, benefit rate, etc. Here are the curves. On the left is the intention to treat overall population, and on the right is the ESR1 mutant population. A couple things before we look at the curves. Over 20% of these patients in both groups, elacestrant versus control, had prior chemotherapy exposure. Almost half of them had acquired an ESR1 mutation, and over 40% of them had had at least 2 prior lines of endocrine therapy. So this is a pretty heavily pretreated population. Here you can see, if we look at the overall curve, there's a steep drop-off in the first 2 months. So somewhere around 40% of these patients are really hormone refractory. It doesn't matter whether they get standard therapy, fulvestrant, whether they get elacestrant, they just show total resistance to anti-estrogen treatment. Then you see the curves start to split. Because of that steep drop-off, the clinical benefit here was pretty limited. In the intention to treat, the median PFS went from 1.9 to 2.8 months, and it was slightly more prominent in the ESR1 mutant population. Here it went from 1.9 months to 3.8 months. Because of the size of the study, the hazard ratios were 0.5 to 0.7 with significant p-value, though I would argue the magnitude of clinical benefit here is somewhat limited because of this very steep drop-off. The authors went on to do subset analyses, and one of the cool things that they found is that if you looked at the amount of time the patient was on the original CDK inhibitor, it seemed to correlate with how well they did on elacestrant. So here you see patients who got at least 6 months, 12 months, or 18 months. And as you move across, you see the magnitude of benefit between the curves actually increase. So if the patient had at least a year on the prior CDK therapy, the median PFS improved from 1.9 to 2 months up to 8 to 9 months. So now we're talking about a 6-month improvement in terms of progression-free survival. And so right now in the US, the drug was approved for ESR1 mutant patients, and most clinicians think about using it for these kind of patients who did at least a year or 2 plus on their first-line CDK inhibitor, because that is what we think predicts the best outcome here. This drug is very well tolerated, as you might expect. There are some typically low-grade toxicities, occasionally some nausea or diarrhea, occasionally some fatigue, hot flashes, low rates of liver function test irritation, very few grade 3 toxicities, as you can see. Most of them are on the kind of 1 to 2% range. So overall, as you might expect, very well-tolerated drug, not a lot of extra toxicity. I would say in my own experience, having used it now, maybe a little bit more GI stuff, but overall very tolerated. And you can see the fulvestrant on the right-hand side there. So let's go back to our case. Remember, 67-year-old woman, no significant past medical history, had some back and hip pain, diagnosed with de novo bone-only cancer, hormone receptor positive, HER2 negative. She did well for 3 years on a CDK inhibitor, new progression in multiple sites, including in the liver. What additional diagnostic workup? Well, here I would want to do next generation sequencing, and I would probably use a liquid assay. And we're looking really for ESR1 primarily. What are the therapeutic options? Well, if she's ESR1 mutant, we could think about elacestrant based on the EMERALD data that we just looked at. If she's got a PIK3CA or an AKT or a PTEN mutation, I'll show you this data momentarily, we could start to think about something like alpelisib or capivasertib, one of these AKT or PTEN or PI3 kinase inhibitors. Those are given in the second-line setting with fulvestrant. And if she has none of the above, the standard of care would typically be fulvestrant alone. We now have some phase 3 data that we could give it with abemaciclib for the post-MONARCH study. So you could do CDK after CDK, though again, the magnitude of benefit here is somewhat controversial. And again, I'm happy if there's any questions for the moderators, just stop me. And if any questions are coming in on the chat, or if anybody wants me to clarify, I'm happy to stop.
Yes, we don't have yet one.
Okay, but you'll just let me know anytime.
Yes, I'm looking for one.
Okay.
And so that was the first oral SERD that was approved in the US. And so here I want to just spend a minute and tell you about a few other newer drugs that are coming and that we're starting to see some phase 1 to phase 2 data. And soon we'll have phase 3. So this was a really nice review that was published last year in 2023, showing all the different mechanisms of anti-estrogen therapy. Here on the left-hand side, you have the aromatase inhibitors and the selective estrogen receptor modulator tamoxifen primarily. So remember, the aromatase inhibitors block the production of estrogen from androgens, and so you're reducing the ligand. Here, the SERM blocks the receptor. It's an agonist in some tissues and an antagonist in other tissues. This is tamoxifen. The SERD promotes degradation of the receptor, but it only degrades about 40-ish% of the receptor. This is fulvestrant and elacestrant. And now we have these newer classes of drugs, Protac, Sirian, and Circa. The Protac is a proteolysis targeting chimera. It effectively brings the machinery of the cell that promotes degradation toward the receptor. So this is effectively a more thorough degrader than fulvestrant. The Sirian is a complete ER antagonist. So unlike tamoxifen, where in some cases it turns on and in some cases it turns off, this is a complete blocker. And the Circa is similar to that. It's a selective ER covalent antagonist. So it sort of permanently binds covalently to the receptor to block it. So when we think about the drugs that we currently have, and then some of the drugs that are in development, this is the spectrum of all of strategies that we're using, and this was very nicely reviewed back in 2023. So let's talk about a couple of the other SERDs. So I showed you the published phase 3 approved data for elacestrant. Let's talk about some of the competitors to that drug. So this is the SERENA-2 trial. This is phase 2, camizestrant, so different company but similar drug. Postmenopausal women, they have to be eligible for fulvestrant. They had to have had at least one prior line of endocrine therapy, and most of them had a prior CDK inhibitor. They were randomized to fulvestrant alone or several doses of the camizestrant. Same thing, primary endpoint was progression-free survival. And here are the curves. And again, it's very similar. You see the steep drop-off of about 30 to 40% of patients here. And you see that there was an improvement compared to fulvestrant, but it was fairly marginal from about 4 months up to about 7 months out to 75 and 150 milligram dose of the camizestrant here. And when the authors did the same thing as they did in Emerald, you can see if the patient had ESR1, you saw the curve shift even a little bit more from about 2 months in the control arm. So the control arm did a little worse with ESR1 up to 6 to 9 months with camizestrant. And if the patient lacked ESR1, there was no benefit for the camizestrant. So just like in the Emerald trial with camizestrant, all of the benefit here was primarily limited to the ESR1 mutant population. This drug is now moving into phase 3 studies, and I'll show you some of those study schemas here in a moment. Here's the ELAINE-1 trial. So this is with a new SERM, selective estrogen receptor modulator. You can think of this drug as a newer version of tamoxifen. So these are for pre or postmenopausal women with estrogen receptor positive metastatic or advanced breast cancer. They must have had ESR1. So this study was only for ESR1, and they must have had a prior CDK inhibitor. Patients were randomized 1-to-1 to get either fulvestrant or the new pill, lasofoxifene, and there were over 100 patients in the study. You can see that most of these patients had measurable disease and visceral disease. A small number of them had prior chemotherapy, but 100% had prior CDK4/6 inhibitor, and about 40 to 50% had this Y537S. So one of the things I didn't mention earlier, we've been thinking about ESR1 as a yes or no, mutant or wild type. But the reality is there are many different types of ESR1 mutations, and we're only just beginning to learn about some of the differences between these mutations. Some of them seem to be worse or more aggressive than others. So the Y537S is a particularly bad mutation that seems to show more resistance to, for example, fulvestrant compared to some of the other mutations. And I'll show you that data in a minute. So here are the curves. So again, look at the steep drop-off. Every single study I'm going to show you has this very steep drop-off here of 30 to 40+%. Then the curves separate, and you see the lasofoxifene, the SERM, beats the fulvestrant by about 4 months up to 6 months. Because it was a small study, the statistical significance wasn't there, so it was really underpowered. But the lasofoxifene beat the fulvestrant in every metric: better PFS, better disease control rate, better overall response rate, better clinical benefit rate. So in every parameter, the patients who got the lasofoxifene were doing better. And you can see the waterfall plots here on the right. This was very interesting, where the authors on this study looked at the different ESR1 mutations. So what you're looking at here is overall ESR1, but this is the D538, Y537, E380. These are all different types of ESR1. And you're seeing the number of patients who had a decrease in this type of ESR1. And what you can see is for every single mutation, the lasofoxifene had a better decrease, had a bigger drop in the mutational load than the fulvestrant. And this was most noticeable for the Y537S, which I just told you is sort of the worst of the ESR1. It's the most aggressive of the ESR1. Here, if you look at the average change in the fraction of ESR1 mutation, the allelic fraction in the DNA, on fulvestrant, there was an 80% increase, meaning the fulvestrant didn't control, on average, the Y537S at all. Whereas on the lasofoxifene, there was a 90% decrease. So here, if you had this particularly bad ESR1, if you had fulvestrant, you were doing worse. If you had lasofoxifene, you were doing significantly better. And so this, to me, it was very impressive data that this newer drug may not only be effective against ESR1 overall, but effective against even the worst of the ESR1 variants. And then I just want to give you another example. These aren't all the studies. I'm just giving you a few examples of some of the newer drugs that are going to be coming in the next year or two. Here's the Veritac study. This is with the Protac. So I told you the Protac is a drug that more effectively degrades the estrogen receptor. It brings the cell degradation machinery right up to the receptor to target it. So this was a phase 1, phase 2 expansion. These patients had at least one prior endocrine therapy, at least one prior CDK inhibitor, and they were allowed to have had prior chemo. They were looking at several different doses of the Protac, this ARV-471, and the primary endpoint was clinical benefit rate, with secondary endpoints including response, PFS, survival, pharmacokinetics, et cetera. And here, 100% of the patients had prior CDK, 3/4 had prior fulvestrant, almost half had prior chemo, and over half had ESR1. So this is a very heavily pretreated population. The overall response rate was about 8 to 10%. But again, the median PFS was 3 to 4 months overall and 5 to 6 months in the ESR1 mutants. And you can see the waterfall plot over here with a clinical benefit rate getting up to 40 to 50% there for patients who had ESR1 mutants. So all patients had a clinical benefit rate of about 30 to 40%. The patients who had ESR1 mutants had a clinical benefit rate of 40 to 50%. So pretty impressive for a heavily pretreated group. So let me turn now to the PI3 kinase pathway. So I mentioned before, I showed you that diagram of all the different resistance mechanisms to hormone therapy and CDK. And one of the key resistance mechanisms are these oncogenic signal transduction pathways, including PI3K, AKT. So here you have the receptor tyrosine kinases that activates PI3 kinase. PTEN is a tumor suppressor that's there to kind of hold back PI3 kinase. Once it's activated, you see activation of AKT, and then you see growth, survival, motility, metastasis. So alpelisib is a PI3 kinase inhibitor that acts at the level of PI3 kinase. Capivasertib is an AKT inhibitor that blocks downstream. And I'll show you the data for these two drugs. This is the SOLAR-1 study that was published a few years ago. This is in patients with advanced or metastatic hormone receptor positive disease. They were basically second line. They had to progress on hormone therapy. At the time, they didn't require CDK, although many of them or some of them had CDK. Now, almost all patients in the US will get CDK in the first line setting. Patients were randomized to receive either fulvestrant alone or fulvestrant plus the PI3 kinase inhibitor alpelisib. And there were two cohorts. There was a PIK3CA wild type cohort or a PIK3CA mutant cohort, between 200 to 300 patients on each cohort. The primary endpoint was progression-free survival in the PIK3CA mutant cohort, but they were exploring endpoints in both cohorts. And here's the curve for the PIK3CA mutant cohort. You can see significant improvement, not as much of a drop-off here because we're not using hormone therapy. We're using targeted therapy with the AKT inhibitor. And you look at the 50th percentile, the median progression-free survival here went from about 4 months up to about 8 or 9 months over here. The hazard ratio was 0.65 with a significant p-value. Now, when you looked at this data for the PIK3CA wild type cohort, meaning they did not have the mutation, there was no difference between the curves. So this led in the US to the approval and the use of this drug in patients with PIK3CA mutations. The last thing I'll mention here for those who may or may not have as much experience with this drug, it's a pretty difficult to tolerate drug. It's not chemo, but it causes a lot of elevated blood sugar. It causes rash. It causes mucositis. It causes GI toxicity, nausea, diarrhea. So this drug has been challenging to give for a number of reasons, and the use has been quite limited by that. And now more recently, we have the Capitello 291 study. This is phase 3, randomized, double-blind, placebo-controlled. Here, patients were allowed to have had up to 2 prior lines of endocrine therapy. They could have had 1 prior line of chemo. Most of them, at least 51%, had prior CDK, but not all of them. And they had to have an A1C less than 8 or some decent blood glucose control. So they were over 700 patients here. They were randomized to fulvestrant alone in the second-line setting, or fulvestrant plus capivasertib, the AKT inhibitor, with progression-free survival as the primary endpoint. And here's the overall curve. You see, similar to what we saw for alpelisib, an improvement from about 3 to 4 months up to 7 to 8 months with a hazard ratio of 0.6 and a highly significant p-value. Now, here I didn't include there's a second subpopulation analysis where they were looking at AKT mutant population, and there was the same. It wasn't just limited to the AKT mutants. So all the patients here benefited from capivasertib. However, the way they did the biomarkers was pretty limited. About 30+% of the patients, I think, didn't have available specimens. They were using a lot of old archival specimens. So it wasn't really clear whether that was kind of real or not, or whether you actually had to have the biomarker. Based on laboratory data, based on other translational data, this got approved in the US, but not for the overall population, just for the population that has the AKT PI3 kinase mutation. Toxicity-wise, this was a little bit better tolerated than the alpelisib. There's still some hyperglycemia. There's still some GI toxicity, mucositis. Overall, it seemed to be a little bit more manageable. This is a 4-day on, 3-day off pill. And so right now in the US, most of the patients who have PIK3CA, AKT, or PTEN, clinicians are reaching for this drug, not the alpelisib, because of all the toxicities we mentioned before with the other drug. So I just want to end, before we go back to another kind of case, I just want to end with a couple of what I think are some of the most important phase 3 trials that are now accruing, that you're going to see data for starting soon, starting actually in the next couple of months into next year. And this is a table, and I'm sure we can share the slides, or if anybody's interested, I can send this to them. This is a table that I put together, not every trial, but just some of the key trials looking at the drugs we just talked about. So we have Emerald and Serena 2. We went through that data today. Those are both positive. There were 2 negative trials that we didn't go through, Amira 3 and Acelera. And then I'm going to show you some of these trials that are still ongoing. As you look at these trials and you spend some time looking them up, you'll see there are some important things to compare. Different control arms, different sizes in terms of population, whether or not prior CDK is required or allowed, whether or not prior fulvestrant is allowed or not. All of these factors can influence what the control arm looks like and what the expected median PFS is going to be. So let's look at some of the key upcoming trials. This is the phase 3 EMBER-3 trial. This is very similar to Emerald, but it's using a different oral SERD, imlunestrant, from Eli Lilly. These are patients with metastatic or advanced breast cancer. They had to have treatment with a prior aromatase inhibitor. Many of them, most of them had a prior CDK, but it wasn't required. They were not allowed to have had prior AKT or PI3 kinase therapy. So this study is interesting because you have the same two arms of Emerald, endocrine therapy alone versus the oral SERD, but you have a third arm, which is the oral SERD plus abemaciclib, the CDK inhibitor. So this is the first phase 3 data that we're going to see with the combination of a next generation anti-estrogen with a targeted agent. This data is ready. The study finished accrual, and I believe they're going to be presenting it very soon in the next couple of weeks at our San Antonio conference. So we're anxiously awaiting seeing these results. This is the ELAINE-3 trial. So I showed you lasofoxifene, the SERM. I showed you the ELAINE-1 data versus fulvestrant. This is the phase 3 data. So here, patients with hormone receptor positive metastatic breast cancer, they had to have progression on a prior CDK inhibitor and an aromatase inhibitor, and they have to have an ESR1 mutation. They're randomized to get fulvestrant and abemaciclib, not fulvestrant alone, versus lasofoxifene plus abemaciclib. So this is the first phase 3 data with a combination study, next generation anti-estrogen, with the control arm also including the combination. So I showed you, if you go back to EMBER-3, there's no control arm with fulvestrant abema. So this study is not really appropriately designed to compare this. Here we have that comparison. And so it's likely, if a study like this is positive, that we'll have a new standard of care with a next generation anti-estrogen and a CDK inhibitor as part of our second line regimen. The primary endpoint is progression-free survival on this one. This study is currently accruing right now. And then this may be the most interesting study of all. So this is the SERENA-6 study. Phase 3, I showed you the SERENA-2 study, which is camizestrant phase 2. So here what they're doing is they're taking patients who are on an aromatase inhibitor and any CDK inhibitor, and they're looking at their blood, and they're testing for the emergence of ESR1. So you have a patient who's got normal circulating tumor DNA. They go on their standard treatment, and every couple of months they get a blood draw. If the blood shows a new ESR1 mutation that's rising, and the patient has not had clinical progression, the scans look good, there's no sign of clinical progression, they switch them early from the standard anti-estrogen to the camizestrant. So they're going to screen thousands of patients to find a few hundred who have a rising ESR1. Those patients, half of them will switch to the newer anti-estrogen, half of them will stay on the same anti-estrogen. And the question that they're looking at here is whether there's any clinical benefit for detecting the ESR1 mutation early. Does it matter if we catch it before clinical progression and actually change therapy in a highly personalized way based on the circulating tumor DNA? So this is a really unique and different study compared to everything that's been done previously. And so I wanted to end with another case and think a little bit, and then we should have another 10 or 15 minutes if you want for discussion and conversation. Here's another case. So this is a patient who's 45 years old, de novo metastatic ER-positive breast cancer, bone involvement. And here I wanted to think about what we would do: first line, second line, third line. And this is sort of our current practice pattern in my clinic right now. So this patient in the first line setting, we would give, because she's younger, an aromatase inhibitor with ovarian suppression or oophorectomy with a CDK inhibitor, and we would probably use ribociclib because it's the only CDK inhibitor with positive overall survival data in the first line setting. Because of this recent FDA approval for inavolisib, if this patient is PIK3CA mutant and she had previously progressed on endocrine therapy, which this one didn't, you could think about inavolisib. That's a new change as of a few weeks ago. But for this patient, I would use this, Lupron, probably letrozole, and ribociclib. Then, if she progresses, we need to look at the sequencing, either circulating tumor DNA or tumor biopsy. If she has a PIK3CA mutation, she could get either alpelisib or capivasertib. We just went through that data. And most of us would choose capivasertib because the toxicity is a little bit better. If she has an ESR1 mutation, I would give her potentially elacestrant. If she has BRCA mutation, we could give her olaparib, which is from the Olympiad study. If she has none of these mutations, she would get fulvestrant with or without, you could think about abemaciclib. The data here is a little bit controversial. Then if she progresses again, then there's lots of different choices. Of course, we have everolimus. That's an mTOR inhibitor. It's been around for a long time. It's got a fair amount of toxicity. We don't really know how patients do on that after something like alpelisib or capivasertib. We have antibody drug conjugates, trastuzumab deruxtecan. Those drugs seem to be better than chemotherapy if deployed earlier, which I'm happy to come back and do another talk if you want to focus on ADCs. Today, my job was to focus on ESR1, but we have ADCs that we can use. Of course, we have lots of different chemotherapy choices: Taxol, paclitaxel, capecitabine, doxorubicin, et cetera. And of course, we have lots of clinical trials looking at new anti-estrogens, new CDK inhibitors, new targeted therapies, PI3 kinase, RAS inhibitors, new antibody drug conjugates with different payloads and different targets. So what about a patient who has both PIK3CA and ESR1? That's a hard choice. Nobody on those trials got the other drug. So it would be you could either choose elacestrant or capivasertib. I think it depends a little bit on how well they did here. If the patient did 6 months on the first line CDK, I probably wouldn't use the elacestrant. If they did a year, 2, 3 years on the first line CDK, I might use the elacestrant first. So I think you have to take into account what drugs they've had, what the molecular sequencing is, how fit the patient is, medical comorbidities, side effects, and make the best choice you can at any given time. And so with that, let me summarize and pose a couple of questions. I showed you that resistance to these drugs, anti-estrogens and CDK4/6 inhibitors, is complex, that the ESR1 mutation is rare if you test at baseline, but is common if you start to look after progression on anti-estrogen therapy. Anywhere from 25 to 50% of patients will have it. I showed you that multiple pathways impact response to these drugs: cell cycle regulatory pathways, RAS pathway, PI3 kinase pathway. We looked at data for elacestrant for patients with ESR1 mutations, and I showed you that the outcomes were better for patients who had done longer treatment course on their first-line therapy. We did some examples of novel oral SERDs, PROTACs, and SERMs. And I showed you that these drugs have favorable toxicity profiles, though there are some that have some unique toxicities, some GI things. Camizestrant and some of the SERDs have shown some visual changes and rare bradycardia. And some of the questions that I have are, will these drugs, these new SERDs like elacestrant, continue to have a role as monotherapy? Or are we always going to give them in combination? And if they're going to be monotherapy, who should we give as monotherapy? Which patients would be best for monotherapy? If we're going to develop them as combinations, what should it combine with? Should we combine it with currently available CDK, newer CDK inhibitors in clinical development, targeted drugs for AKT, RAS, et cetera? The answer might be all of the above. We need to develop safety and efficacy data for all of the above, I think. And then how do these new drugs fare against specific ESR1 mutations? I showed you some data for lasofoxifene, but we don't have that data for most of the other drugs. What about patients with polyclonal mutations, meaning they have more than one ESR1, multiple variants? What about patients who have both ESR1 and RAS and AKT? So we need to start looking at this. And then how will we use dynamic kind of real-time ctDNA to inform our trial design? This is the SERENA-6 study that I showed you, where they're actually monitoring patients for the emergence of resistance. So I predict over the next 5 years or so that all of these drugs, the SERDs, the SERMs, the SERCAs, will hopefully succeed and will have important roles to play. I think eventually that we're going to deploy specific drugs based upon the genomic profile of the tumor, probably in combination regimens based on what mutations the patients have. But we have a long way to go to get from here to there. So with that, I think that's my last slide. Yep, that's my last slide. So I'll pause there. I think we still have about 10 minutes left if people have questions or want to chat about anything.
Okay. Thank you very much, Dr. Seth. Yes, we have questions. I think Eugenie Basham have question too, and my colleagues are looking for the chat questions. And I really appreciate your work. It was very nice to show the whole picture about the actualization for breast cancer. It was very complete with all the treatments available and specific with this kind of mutation. Is very important to have here in Argentina, in Latin America, because it's going to be the first time for these patients, this woman that they are trying to, the doctors want to give hers to give them an answer because they are waiting for that. So thank you very much for the presentation. I don't know, maybe Eugenie are there, that because I know he has question for you, and maybe something in the chat. Okay.
Thank you so much, Seth. It was brilliant presentation. I have just a couple of questions, maybe 1-2 questions to raise, if you allow me. So, first of all, really impressed some outcomes of the clinical trial you cited. So, for example, it's Emerald and in particular Serena 6. So, do you think based on the some positive outcomes of third treatment with third, do you see any future, let's say, combination, for example, of elacestrant or another SERT with other drug, like not specifically targeted drug, but for example, immune checkpoint inhibitors or some other settings?
Yeah, great question. Probably yes. As you may know, that immune checkpoint inhibitors have been disappointing in ER-positive breast cancer in particular. We've not seen great responses. We don't totally understand why. And I think strategies to develop combinations with ADCs or immune checkpoint, is likely to come online. And I think, my question about what's the best combination with these drugs is an open-ended one. I mean, obviously we have CDK and we have PI3K, but you could imagine lots of other new things, coming up. And I don't see any reason why these drugs couldn't be combined because they're so tolerable, right? And because they have such limited toxicity. I think it gives us opportunities to combine not just in doublets, but in triplet therapy as well, where you could have a CDK and a PI3K or a CDK and an immune checkpoint plus anti-estrogen. I think it's just going to take time for the companies to spend the money to develop the safety data, to prove that, and to decide kind of what the right doublet and triplet combinations are.
Okay, thank you. And the question about to go to the early lines, it's also could be interesting or not, because we know that it's acquired mutation mainly on CDK4/6 inhibitor progression.
Yeah,
so
great question.
Does it make sense to go early or
yeah, I for the sake of time, I didn't include some of these, but there are a number of big phase 3 trials right now, not just in the first line metastatic setting, but also in the adjuvant early stage setting. So we're participating in a trial, for example, where patients with stage 2 to stage 3 disease, they do anywhere from 2 to 5 years on standard, tamoxifen, letrozole, anastrozole. Then they come into the study and half of them stay on whatever pill they're on, half of them go on the new SERD, the oral SERD. The question, Evgeny, I think behind your question is, how effective will these newer drugs be in a population with less resistance, with less ESR1? Will they be the same as the currently available drugs? Will they be better? Will they be worse? And I think we don't really know. I'm not sure they would be worse, although anything's possible, but they may not be better. And then you have a drug that's been around for 30 years that's fairly inexpensive versus a drug that's extremely expensive and has only been around for 30 days. And I think in that case, it's going to be a tough sell to use these drugs early. But they definitely are testing them. The companies want them to go early, right? Because that's obviously bigger population, longer treatment. But I think it's very tough to beat our current therapies in the adjuvant and first line setting because they do well, right? Our patients tend to do well. So it's a steep mountain to climb compared to the second or third or fourth line setting.
Yeah. Okay. Thank you. My last short question. So we know that it could be concurrent mutation, for example, ESR1 with PIK3CA, for example, in some cases after progression on CDK4/6. So if you are facing this case, which treatment do you recommend in this case?
Yeah, this is a very common question right now in tumor boards, and there's no right or wrong answer. Nobody on Emerald, got PI3K directed therapy. Nobody on those PI3K related trials got oral SERD therapy, right? So in the real world now, we're combating this. I'm going to answer your question two ways. I'm going to play devil's advocate and play both sides of it, right? So I'm going to argue first for the elacestrant. I would say you could give elacestrant, particularly for a patient who did really well on the first line, who maybe has a small amount of disease, bone only, slow growth, not a lot of symptoms, because it's tolerable, minimal toxicity, easy to give oral drug, and because patients with that long first line response do well. On the other side, let me argue for the alpelisib or the capivasertib. You might say, look at the curves for the overall population on Emerald. They were not that impressive. It was like a 1 month PFS benefit, and we're talking 2 to 3 months, right, total. And here you're actually targeting the oncogene, where you're seeing curves shift out more towards 7 to 9 plus months. So for a patient with a targetable oncogene with an overall population on the phase 3 data that has more clinical benefit, I would reach for the, capivasertib or the alpelisib. So I think it goes both ways. I'll tell you what I would prefer to do if I can is if I have a clinical trial with both, with like an oral next-gen anti-estrogen plus a PI3K, that's what I really want, right? What we really want to do for a patient with dual mutation is be able to give them both drugs at the same time, but we can't do that yet as standard of care.
Yeah. Okay. I see. Thank you so much. I pass the microphone to Clarissa. Thank you, Seth.
Thank you. We were looking at the chat. We don't have questions, so and here we talk about the audience because here this is virtual. It's hybrid. We are in the clinic in the class. There is no question. They were so happy to have such much information you gave us. It was very complete. So I don't know if you have something to finish and something to tell us before we finish.
No, I mean, I'm it's been my pleasure. I'm very happy to come and chat about any of these topics. I know we touched on a few other things. We touched on ADCs, and there's a lot of other topics of interest. I think, these drugs are being developed at incredibly fast speed, and we as clinicians have to absorb this data and try to compare across trials, which is always really hard to do because the populations are different, the inclusion criteria is different, the way they do the scans and the endpoints are different. And I know it can be confusing because even those of us who only do this, and this is all we do 24/7, it's still confusing. So I feel the challenge for my colleagues who are practicing all different kinds of cancer, not just breast cancer, GI cancer, thoracic cancer. It's a lot to keep up with. The message I would say is we're doing our best to develop well-tolerated drugs and to help you get them to patients in a personalized way so that we know this mutation should go with this drug. This mutation should go with this drug so that we're not giving unnecessary toxicity to people and we're giving drugs to people who are the most likely to succeed, with that drug. So, that's been our guiding philosophy as we meet with the companies and as we work on the biomarker piece. And I think we're entering kind of a new world, not just in breast, but in lung and in GI. These are the same themes that I'm sure when you have other speakers talking about next generation ALK inhibitors and next generation BRAF inhibitors, right? It's the same kind of concept that we're learning more about the genetics, and we're doing a better job designing drugs to fit those genetic profiles of the tumor. We want to get away from using the toxic chemo. We want to get away from linking our patients to the IV, sort of forever. And I think we're starting to make progress, although we have a lot of work to do.
Yeah.
We have one because, I raised one of the audience. So I have a question. Do you have time to answer?
Yeah, of course. Yeah. Yep.
Okay. The question is, how long until the disease remission using elacestrant can be changed the natural history of the disease?
Sorry, how long until the what?
The disease remission.
Oh, how long until disease remission, can elacestrant change? Like, meaning if you have a metastatic patient, you put them on elacestrant, how long until you can achieve a remission and control the disease? Yeah, I think it's a good question in that we have some data that we're working on a manuscript right now where we're looking at the real world. So we look at claims, insurance claim-based data to look at who's using elacestrant, what line of therapy they're using it, and how long people are staying on it outside of the clinical trial in the real world. And we're starting to appreciate the patterns of how long. I think in my experience so far, it's unlikely in the metastatic setting that a drug like elacestrant on its own can achieve a remission, meaning like you can't see anything on the scan. It seems more likely that it can achieve maybe some response or more likely control, stability of the disease, where it's not really in remission because you can look on the scan and still see, the spots. They're not growing and they're not really shrinking. And even if you were to achieve a remission, even if you get the ESR1 in the blood all the way down and the scan looks good, we have to assume that there's still some microscopic disease that we can't see. And so, we would keep patients on the treatment and continue to monitor them with, laboratory studies and scans kind of indefinitely. I think we're still learning a lot about who's responding the best to elacestrant, who's getting closest to that notion of a remission. Can you ever take a break, from drugs like that? I think it's unlikely, but there may be individual cases. The other thing I would say about hormone therapy, and I think many of the folks watching this will probably agree from clinical practice, in my experience, when you give someone an ADC like trastuzumab deruxtecan or chemo, it can debulk the disease quickly, right? Whereas when you use an anti-estrogen, it can take a long time for the cancer to start to respond. I've had patients on fulvestrant where for 2, 4, 6, 8 months, the cancer doesn't get better. And then all of a sudden, 6 months in, 8 months in, it starts to decrease on the tumor markers and on the scan. I can't fully explain why the kinetics for that patient, were so far delayed. But this question about how you can achieve a deep and durable response, I think depends a lot on the patient. And sometimes you have to wait a long time to see it.
Mm-hmm.
Great. Thank you, Dr. Seth. So I think we finish here because we don't have more questions. So thank you very much. Thank you for Asiapo Foundation, because this is possible about Asiapo Foundation is a patient organization that it's her objective is to increase the awareness of the disease. Asiapo Foundation is it's working for 70 years since launch. So I would like to ask Dr. Marta Asiapo to come here to see and to give us the last word to finish the event. Okay.
Thank you.
Just a moment, please.
Soy Marta Artigas. Hola, ¿qué tal? Buenas tardes. Soy Marta Artigas, presidente de la Fundación de Cáncer Asiapo, Atención Comunitaria Integral al Paciente Oncológico, que fundé hace 27 años en razón de la enfermedad de mi hijo. Y bueno, les puedo decir que estamos muy contentos y muy agradecidos de estar aquí, de que poder compartir conocimiento. Tenemos un programa que se llama Educación y Cáncer, y ese programa desarrolla hace muchos años estas charlas para el beneficio, no solamente el conocimiento de los profesionales, sino también para el beneficio y la sobrevida y, por qué no, la curación de todos los pacientes, en este caso de cáncer de mama. Bueno, una alegría estar acá y los saludo con mayor afecto. Muchas gracias.
Damos el cierre de la charla. And thank you to Marta, and thank you to you, Dr. Tess, to have this evening. You are in Boston. Here we are in Argentina. You know, people are from Colombia, Chile. Many people are looking at you. And so we're very happy. And I hope that we have next time to see you again talking about the actualization of breast cancer. Thank you very much.
My pleasure. Thank you for
Thank you, Seth.
It's a great pleasure to be with everybody. Happy to connect anytime.
Okay.
Great pleasure. Much appreciated. Thank you
you.
so much.
Thanks.
Thank
Bye-bye.
Thanks you. Bye bye.